So, as mentioned, my name is Dr. Melanie Carminati. I'm a specialized physical therapist specializing in chronic pain, EDS, hypermobility, and pelvic health. And at my practice, TMJ dysfunction is a common condition and presentation that patients who have EDS and hypermobility present with. And I will be talking about what we do in my practice. I'll be getting into a little bit of the anatomy and then allowing for the other featured doctors for this evening to cover more details about treatment modalities and procedures that they use with our patients. As a reminder, this is educational in nature. This does not substitute individualized medical advice. So if you do have TMJ dysfunction and you want specific guidance for your unique presentation, I encourage you to see one of the specialists featured in this presentation or a specialist in your area. So I'll cover first just foundations. What is the TMJ joint? What is TMJ dysfunction? Why hypermobility and EDS changes risks and priorities? What are some of the red flags? I'll talk about evidence-based PT building blocks. Education is something that we do for all patients who have EDS, hypermobility, and the related comorbidities, so that we can understand what is happening in this person's body and then allow for behavioral change. We'll talk about exercise. We'll talk about the cervical spine, thoracic, some manual therapy depending on the person. And then we'll put it together for physical therapy. I'll finish up with talking about how multidisciplinary care is so important for pain relief as well as joint stability, especially because of this connective tissue nature of EDS and HSD. We'll be sharing the recording after tonight, so don't worry, we will send that to you. Okay, so TMJ dysfunction. So what does this involve? So we have mastication muscles, so the jaw muscles. This can cause, if there's dysfunction, there can be tightness, you can experience fatigue, you can experience pain in the muscles of the joint. Temporomandibular joint, you can have joint pain, clicking, catching, locking, headache, ear symptoms. This is all related to the mechanics of the jaw as well as the neck. So clinically, what are we thinking? Pain related. What are some of the presentations? Is it myalgia, muscle driven, arthralgia, joint driven, headache that's contributed or attributed to the TMJ dysfunction? Intra-articular, we have a disc in the TMJ joint itself. This can cause dysfunction if the disc is not reducing, if there's degeneration in that joint itself. Are there just generally movement issues, especially with hypermobile people? Is there an excessive amount of mobility in the joint? Or is there a limited amount of mobility? Is something stuck? What is going on? So if you look over at the image, you can see some of the muscles. We have the pterygoid muscles, mandibular fossa, the socket of the joint. You can see with the numbers, everything is labeled for the anatomy there. It's a very small space, but there's a lot going on there. So when we are doing physical therapy and we're doing an assessment, we have this in our mind when we're assessing range of motion, when we're feeling the muscles that attach into that area, and considering what is the driver of the pain. Some contributors to TMJ dysfunction include ligamentous laxity, if there's too much translation or small amounts or what we call micro instability, muscle guarding overuse, if someone's clenching their jaw, chewing, other kinds of compensations, proprioceptive deficits, extremely common in people with EDS and hypermobility, neck and upper quarter involvement. So this is having poor posture or having that forward head, rounded shoulder posturing. When we teach patients about posture in physical therapy, we talk about the ideal. We know that no one stays in that ideal stacked posture with the head over torso, torso over pelvis the whole day, but we want to maximize the understanding and that mind-body connection of where ideal posture is so that when you might move out of that posture, you can notice it right away and restack the posture. This is something that it takes time and it takes proprioceptive training, but it's one of the best tools for an immediate change in pain reduction. So there's higher rates of persistent pain in HEDS and HSD. And we have talked about, chronic pain and sensitization in past presentations. So we already have that general understanding. So what are we prioritizing clinically? Controlled range, symptom guided loading, avoiding aggressive stretching or repeated end range testing, and using external feedback, mirrors, just fingertip cueing to retrain the motion. For people who have EDS and hypermobility, proprioception and that body awareness is decreased or challenged. And so anything we can use externally to improve that proprioceptive awareness is going to help expedite rehabilitation and help allow for longer lasting changes. So what are we looking for in physical therapy? We're looking for quality of jaw motion, opening pattern. We're also looking at the cervical spine. So your neck, is there a straightening or is there a curve? Symptom behavior, what happens with chewing, yawning, talking, stress, and sleep. Palpation, masseter temporalis. These are the most common muscles where I find myofascial trigger points in my patients who have TMJ dysfunction. What does that feel like? The neck muscles. So the muscles, we could be thinking about the scalenes, upper trap, everything in that neck region. There may be trigger points there as well. Joint signs, is there clicking, tenderness? Does it feel like it's giving way? Locking history. And then, as we already mentioned, cervical spine and upper quarter, posture, as well as testing the deep neck flexor strength and endurance, and scapular or shoulder blade control. So if someone comes in for physical therapy and they're presenting with some of the symptoms and presentation that I've listed under safety and urgent referral, such as the jaw being stuck closed or stuck open and it doesn't resolve, if there's facial weakness, numbness, vision changes, severe dizziness, fever, swelling, you see all this there, major trauma, I am referring them out immediately because this is something that needs further medical care. So if this is ever something that presents for you, be sure to follow up with the medical provider as soon as possible. What we're tracking in physical therapy is pain intensity, irritability, what is the function of the TMJ with chewing, talking, yawning, sleep quality, range control, and then other psychosocial factors. So for myself, with what we are tracking in terms of pain intensity and irritability, this also directly connects to how I will determine if and what manual therapy I will do. So some of the principles that we utilize in physical therapy include stability before mobility. We know because of that hypermobility and the excessive mobility of the joints, we want to focus on stabilizing those joints. Low load, then progressing to higher endurance, using gentle isometrics, motor control exercises before ever going to any kind of resistance. Proprioception and feedback, we're using that right from the beginning with all exercises, and going over pacing and flare planning. Flares, pain flares, they happen. We want to talk about it and provide tools for managing when those pain flares happen and how to manage, how to modify exercises, what other modalities you can use to help reduce the pain when a pain flare happens. And then pacing, there's many strategies for pacing. And in the beginning of physical therapy, there is a bit of a learning curve for myself and the patient in knowing how their body responds. So communication is something that we encourage a lot because you all, if you are patients who are listening to this webinar, you all know your body is best. And so giving us that feedback about how your body feels after exercises, during the exercises, a few days after the exercises is really helpful information for us to safely progress you in your therapeutic program. So some things that you can be tweaking in terms of habits, having the lips together, teeth apart, that reduces daytime clenching, avoiding prolonged gum chewing or chewy foods during flares, yawning with support, hand under the chin to avoid maximum opening, chewing evenly. So we have a tendency to want to chew on one side and making sure we're evening that out. Heat is amazing for all muscle related tightness spasms. So using heat, a warm compress is needed, and short periods of cold directly on the joint. I use vagus nerve manual therapy as well as vagal toning exercises with my patients to promote that autonomic nervous system response. Many of the vagal toning exercises are similar to voice warm-ups and vocal warm-ups. So if you're a singer and you have that vocal training, it's something that I always encourage because especially if we're in a chronic pain state, we need to be addressing the central nervous system and using those vagal toning exercises as well as vagus nerve manual therapy is great to help expedite recovery and really shift that person out of the sympathetic overdrive and into parasympathetic state for healing. When someone's doing exercises, rule of thumb is always to be keeping the symptoms less than 2 out of 10 while they're going through their exercise program. And then during, if there are symptoms that spike and or the joint feels unstable, we will reduce the range, shorten the exercise session, or shift into relaxation and gentle control instead. These are just some demos of what we might be doing in terms of exercises. Tongue up, teeth apart, isometric opening, mirror controlled hinge. You can see a dosage here. We talk about how much effort you want to feel when you're doing these exercises. Sometimes, many times, we overdo the exercises and we put too much effort into it, and those compensatory movement patterns and bigger global muscles kick in. And so really taking it slow and being mindful of how much effort you're putting into the exercise is important. So in terms of progress, what we want to be looking for, what does the good form look like when you are wanting to progress your exercises? What is the quality of the jaw opening? Is there a smooth motion? Is it minimal effort? Do we not see any compensatory muscle guarding? Symptoms remain predictable and it settles within 24 hours. And I am going to move into the next slide. So we already talked about forward head, round and shoulder posturing, headaches, neck pain. Many of the things that we start with in PT include deep neck flexor nods, scapular sets, and then using specific timing. There was one, here's the image. So I wanted to just be able to show the temporalis here. If you're someone who experiences TMJ discomfort, pain, this is one of the mastication muscles that I mentioned in the beginning. I will commonly work this muscle, different type of trigger point releases or myofascial release in this area, and it does help to relieve pain and discomfort in the TMJ joint area. So I'm going to move through this quickly because I know that the other doctors are going to be covering this in terms of splints, night guards, dentistry. For chronic pain in general, we do use a multidisciplinary approach and bringing in different psychotherapists as well, especially pain psychologists, medications, sleep and airway screening is important in terms of sleep apnea. And yeah, I have a lot that I could go through here, but I want to just move into the multidisciplinary approach. So we have Dr. Nojan here, and we have Dr. Siefferman, and they will be talking more about the other treatments and procedures that can be used for people with TMJ dysfunction. Here's some of my references. And before I wrap up, I just want to say that there is a connection between TMJ dysfunction and pelvic health and the pelvic floor. If you are a provider or just a very informed patient who wants to learn more about pelvic health, we're having our accredited conference on March 14th here in New York City at the Coffin Music Center. It's an all-day conference featuring various pelvic health providers. There is a hypermobile and EDS thread throughout the conference, so there will be some EDS specialists speaking, and then our evening is the endometriosis symposium. So if you're interested in this, would love to see you there. I'll be back at the end for questions. And stopping the share. Okay, thank you. Dr. Nojan, you are up.
All right. I'll go next. Just a moment. Let me take over presenter view. Okay. All right. That was a great presentation. And I'm going to talk about the dental perspective on it. Um, when we have patients that have hypermobility, we always try to utilize physical therapists, physiatrists, and any other providers where it makes sense if there's a rheumatological condition, et cetera. So just want to confirm that you guys can someone confirm that you can see my slides?
Yes.
Awesome. Okay. All right. So um, I teach, but I also am in private practice. I have my own private practice in New York, in Manhattan, and this is all I do. So I limit my practice to really like TMJ disorders, orofacial pain, and sleep apnea that can be treated. And there's an overlap between hypermobility and sleep apnea. So depending on where you are located, if you are in New York, you're in luck. There's several providers who would do whatever we do, but we know there's a shortage. So just by going to any dentist, you might not get the sort of care that you need to be able to manage this. Dentistry is a tricky situation when you're hypermobile. It's really good to speak up about it, let your dentist and hygienist and everyone else know because we know dental appointments can be very triggering. Being wide open for 30 minutes is going to destabilize everything that you just heard in the prior presentation. So in the country, there's about 380 of us. And if you are in search for one, you can go to this website called abop.net, where the board certified orofacial pain specialists are listed. That's the official term of the specialty. And it's taken me to fun places like Hawaii because of it. All right. So what is TMD? Because there's a lot of confusion both amongst providers, dentists, clinicians, physicians, everyone, what it actually is. So a lot of people tend to clump everything together and call it TMJ or TMD when it's actually not. So, and then because of that, the treatment tends to be a lot of times not customized or personalized, and the same routine treatments are provided. So you may have heard, give a boy a hammer and everything he meets is a nail. It's an old saying. We're not really sure of the source, but we're sure of this source. This is me, give a clinician Botox and everything that meets is clenching or grinding. Okay. It doesn't matter why your jaw hurts, it's always clenching or grinding. And that's not quite true. And later on, we'll learn why Botox is actually not a great idea in hypermobility and TMJ disorders. So how do we know that we're really talking about TMD? It has to meet certain criteria of pain description. So throbbing is not really TMD, electric is not, burning is not, stabbing is not, tingling is not, headband-like is not. It's really just these three bottom ones. If it's dull, shooting, or sharp pain, then it's probably TMD or TMJ. It has to be in the muscles of the jaw that are involved in chewing, so the masseter or temporalis, or the joint itself, the hinge right in front of the ear. Okay. If your pain feels more like there's something gripping your head, because sort of like this art piece in the Whitney Museum, that's not TMD, TMJ. That's most likely tension type headache or another variant of a headache presentation. If you have any of these things, changes in your vision with your jaw pain that occur, it's also not TMJ. It just happens to be a migraine that instead of presenting in the head area or in the sinus area or in the upper jaw, it happens to present in either the teeth or the chewing muscles. And treating it like TMJ is actually not going to get you very far. And treating it like a migraine will actually help you a lot more. So this was already discussed. I'm going to skip ahead. We already did the anatomy. But one thing I want to point out in hypermobility conditions, the disc that's positioned between the lower jawbone and the upper jawbone is loosely attached and it's expected to move more, click more, and later on, once it's a little more worn down, it might make more crunchy, rice papery sounds. That's when it starts being worn down. Um, there are several issues why this happens in hypermobility conditions, whether it's the knee or the back or anywhere, the neck. It's not just the mobility of the disc, but it's also, we believe the tissues are a little bit different in patients with hypermobility and EDS. So this was already covered, so I'm going to skip ahead. All right. So if you find yourself, this is supposed to be a frontal view, and it might be a little easier if I do it on the skull, but if you open your jaw and you close your jaw, and your jaw veers off to one side, but then comes back to the middle, that's not a big deal. That's very common. That's about 60% of the population. It just means that the cartilage that's between those two structures is a little bit more loose. It goes off the one side and comes back. That's okay. That we just monitor, we make sure that it doesn't progress. And very importantly, we do not do the standard, what's known as the standard TMJ treatments like Botox mouth guards, because they can actually destabilize the joint and the structures and make it worse. It can take it from something normal to something abnormal and pathological. So we just educate our patients when that occurs, or a lot of our patients luckily have already looked that up on their own and they know that's very common and they're not too concerned. When we do intervene is when someone's jaw goes off to one side and they can not open past that and they have a limited range of motion. That's when the cartilage on that side is displaced, it's out of the socket, and one is not able to put it back in. So when that happens, you want to try to treat it as quickly as possible. You want to see someone with my sort of with that orofacial pain training because we're able to get the disc moving again as long as we intervene within a short time duration. So it's very, very easily treatable in the first 2 months. That success rate tends to decline around 4 to 6 months. And if you wait beyond 6 months, it's usually chronic and you just let the disc stay out of the socket. You actually don't try to get it back in anymore. Imaging, when you have any of these TMJ conditions and you have hypermobility, you want to make sure that the appropriate imaging modalities are used. A standard image that's used in a dental setting would be a panoramic X-ray that does a flat image. But unfortunately, it misses a lot of things. So there's better imaging modalities available nowadays, like CT scans or cone beam CT scans that can pick up bony changes, erosion, and Dr. Siefferman will talk about using ultrasound, but I'm purely talking about imaging of hard tissues right now with a CT scan. So this was an example where a patient looked perfectly normal in a panoramic X-ray. We just couldn't explain the pain. So we took a CT scan, and there we could see that there's pretty significant sharp parts in that jaw joint developing. So I'll go to that, like right there. I don't know, there's like these pointy parts that are sharp, and that's why the patient was hurting. So if um, someone cannot find out why the pain is occurring, sometimes you go to the next step of imaging. A cone beam CT can be very useful for assessing bone anatomy. All right, I'm going to skip ahead through this and get to the part that I think is unfortunate that occurs. So this was a patient that was injected for jaw pain with hypermobility, 8 rounds of Botox with diminishing relief each time. I don't understand why after the third or fourth round, people didn't assess and take a different approach to it. But this is someone with not just hypermobility, but a severely eroded joint that should be managed very differently than Botox. This one is by a medical colleague. It was a dermatologist office. 3 rounds of Botox. This person has advanced erosion in the joint. that again can be managed much better with other modalities than Botox. Botox is not really indicated for this purpose. So another modality that can be done to assess it is to do soft tissue imaging of an MRI with an MRI to see where the cartilage, that disc is that was presented in the previous lecture. So the disc will only show up in an MRI. Very hard to read, but this dark area, small area, and MRIs don't always pick up disc pathology because the joint is very small, and MRI slices tend to be 2 to 3 millimeters apart. So a small disc could be partially missed in the imaging. So you might have a normal MRI, a normal MRI report, but actually have joint issues pertaining to that disc. This is when everything goes right. This patient was treated, her jaw was locked for 18 months. Well, not everything went right. I wish we had seen her sooner, but she found us eventually. Her jaw was locked for 18 months. It was a collaboration between myself and an oral surgeon that rinsed out the joint. And she was able to, after 18 months, resume full jaw opening. So this is the after. She's able to open, and this is an example of deviation. It moves off to the left, and then she's able to come back to her full range. So there's a before and after the procedure, it went from 29 millimeters to 46 millimeters. There's a return of the click sound on the left side, which is very promising. And the movement changed from that sort of deflection where the jaw was going off to the side to coming back to midline. So key thing here is no Botox. Okay. I'm not anti-Botox. I use it in my practice at least once or twice a day, but I'm very selective as to who I give it and provide it to. Okay. And the other element in this success story was we got to get a type of splint that's good for someone with hypermobility, not something that makes the situation worse. So I'll talk about that in a second. Um, I'll skip ahead, but here's an example. And this one, I didn't use injections. I didn't use anything. I used physical therapy modalities. This is a patient where you can see the jaw locked. This is how she came in, 25 millimeters of opening. Okay, the disc is slipped. And you see this very commonly in hypermobility. And this is right afterwards. We did a little bit of traction work, and it's 46 millimeters. No Botox, no injections, no joint injections, just early intervention that saves a lot of trouble down the road. When it comes to medications and hypermobility, we have to be a little bit careful. We don't want to use things that destabilize or make the joints any looser than they already are. So I tend to avoid muscle relaxants and magnesium. If I really have to use medications, we'll go to these other class of drugs, like low-dose naltrexone, gabapentin. But generally speaking, I try to avoid it unless we have to. Now, this is, I think, the single most important thing that I always, when I give this presentation to dentists and oral surgeons and everyone else, they're surprised that there's such an importance in appliance selection. But it really is important because, in general, for TMJ, this is not for hypermobile patients. You have a lot of different choices. You have things that can cause harm, like all the way on the left here. They can cause bite changes and issues. That's why we want to avoid them. And there's like a wider range of appliances that you can use for TMJ disorders. But when it comes to someone who has hypermobility, the rules completely change. You do not want to have any standard night guard because anything that's flat allows the jaw to slide into any possible position, and it can actually cause more instability. It can cause issues in the neck and cause the jaw to lock up. So it's really important that in those scenarios with anyone with hypermobility, the population that we are speaking about, the audience that we're talking to, that we either do nothing, no appliance, that's neutral, that's safe, because our natural teeth have cusps and nooks where they're stable in the middle of the night if you clench. But if you're going to do something that's flat, it allows the jaw to slide around, and it can take you from a clicking jaw to a jaw that locks up. So it's very important that if you're going to use a mouth guard for this, that you do something that looks like this. I have one right here as well. I just want to show you. So it goes on your upper teeth. And the difference between this and other guards is that um, it has this curtain in the front. It's not meant to push the jaw into any new position per se, but it's meant to prevent the jaw from sliding backwards. So it goes on your upper teeth, and while you're wearing it, it prevents introducing a new level of instability into the jaw. So if a mouth guard is needed in someone that's hypermobile, you want to do something that provides some stability. The other thing that can pertain to people with hypermobility, some of them have a comorbidity or another condition of sleep apnea or snoring. They tend to go hand in hand between hypermobility and airway collapse. If there's a TMJ component to that, another route you could possibly take is treat the sleep apnea, the snoring with a mouthpiece that holds the jaw in a certain position, but also stabilizes the jaw joint so it doesn't slide around as much and cause instability. So the big takeaway lesson here is no appliance is safer than most appliances. If you're going to do an appliance, you want an appliance that provides stability, not mobility. Okay. So I removed some of these injection videos because I thought some of them might be a little too crass and jarring, but you can see them. I have them on my social media. But sometimes in people with some with people with hypermobility, because they can open so wide, they go and injure their temporalis tendon inside of their mouth. And there's ways to inject that to provide relief if you have to. But the first line treatment is always physical therapy. If someone's jaw is locked, we can inject the jaw joint. But I'm going to skip that because we already talked about it. So why am I concerned about Botox injections in hypermobile patients? Um, is that can cause more instability, which is not something that we want in hypermobility. It can cause so much, and I've seen this unfortunately. Um, it causes so much instability that there's actually a jaw dislocation where the patient ends up in the emergency room with the jaw out of the socket and the jaw wide open. Because if the masseter muscle and the temporalis muscle are the muscle slings that are trying to hold this together when the patient is hypermobile, and you partially paralyze those for 2 to 3 months, sometimes longer, the jaw can move further out. So it can cause jaw dislocations, which are very tough to manage and really unfortunate. In reverse, it can actually cause lockjaw. And that's because of that unique disc that was described earlier. It can cause an internal instability within the jaw joint. And if you only inject the masseter and only inject the temporalis muscles, the lateral pterygoid muscle pulls on the disc more and can actually cause the disc to slip out. And then you end up with a lockjaw. So Botox should really be avoided. I use it in very rare hypermobility patients. I use it very rarely. And if I use it at a microdose. Like we're talking about a third or fifth of what I usually would use for other TMJ patients. The other real concern about Botox in general with TMJ, there's several studies. This was the original study, and it's been repeated since then, is that it causes erosion in the joint. So repeated injections in the masseter and temporalis can cause bony changes in the jaw joint. So we really want to minimize how often we inject those muscles with Botox. Not everyone is impacted by this. I have patients who've been injected with Botox for more than 6 years, every 3 months, and when we image them, they have no erosion. But in hypermobility, we're particularly worried about joint fragility and disc fragility and those type of bony changes. So introducing Botox is not very optimal. All right, and that's it. If you are interested in learning more, I can try to keep my Instagram as information as possible. My handle is over there. And thank you for listening to this. I hope it was helpful. I'll hand it over to Dr. Siefferman.
Hi, everyone. Thank you again for joining us. And thank you, Dr. Nojan, for joining us. It's a pleasure having you. It's great to hear your take on a lot of these things. And I just want to give everyone a little bit of maybe a 30-second break, just to, if you need to stand and stretch, move around. And then I'm basically going to jump in and wrap things up. I'll try to put a nice little bow on the whole diagnostic treatment process. And then we will open up for questions at the end. I think I just lost my screen sharing. Great, here we go. All right, so I'm an interventional physiatrist. So I'm a PM&R doctor who did an interventional pain fellowship, and I'm also board certified in headache medicine. So I treat all of the above. I will rapidly go through a lot of this anatomy because you've seen it several times before. I'll point out some things that are relevant for us to talk about. We'll talk about a lot of the related conditions. We'll talk about joint-specific treatment options, and then we'll look at regional treatment options because, as Dr. Nojan and Dr. Carminati both said, it's rarely just the TMJ in isolation. It's often more than that, and we really want to understand everything that's going on so that we get the best outcomes. All right, again, it's a polycentric joint, meaning it's not like the shoulder or the hip where there's just one center. This is a joint that actually glides as it opens. And that's why the meniscus moves. That's what makes the joint a little complex. And that's what creates the opportunity for that meniscus to pop out and get stuck. Now, the interesting point here is there is a muscle which guides the motion of the meniscus. It's the lateral pterygoid. And the lateral pterygoid is one of those inner jaw muscles. So there's the lateral pterygoid and the medial pterygoid, and each of them have two heads, and they are on the inside of the jaw, also affecting tension across the joint. So if you're having clicking, popping, locking, it's dysfunction of this polycentric motion. And again, the muscles, the temporalis, the masseters, it's important to note that the masseters, it's actually two parts of the muscle, if not two separate muscles that are just named together. There's the deep masseter and the superficial masseter. They are distinct. And if you are going to, your local med spa for Botox, make sure they know the difference. I'm just kidding. Please don't go to your local med spa for Botox. And then, of course, there's the lateral pterygoid, which has two heads, and the medial pterygoid, which has two heads. Now, when a joint is hypermobile, doesn't matter which joint, what is the body's natural response? If something feels unstable, if something feels insecure, the body will tighten up. So all of the muscles that will tighten to provide stability. The other thing is that we develop a compensatory posture. So we're going to position our head in a way that makes the jaw feel more stable. And this may not be the best for the neck, and it may not be the best for the jaw, but it's what we do. It's how our body is reflexively programmed to operate. So, of course, do patients come in saying my joint is hypermobile? Not usually. They come in saying my muscles are tight, which is why they go for Botox, right? And they have reduced range of motion. They will have muscle pain because they are overusing these muscles for guarding. And then they may even have joint pain. So when a joint is hypermobile and these muscles are working overtime to hold it together, often the result is increased tension on the actual joint surface, increased pressure on the joint, because you are overusing the muscles to stabilize the joint, to the extent that you might even be overpressurizing the joint, or you might be restricting the range of the joint and overusing part of that joint range. So you can actually develop primary joint pain from muscle overuse from guarding a loose joint. So how do we address this? What do we accomplish with PT? Melanie went over that nicely. PT is really to gain insight on how you are using the joint. There's proprioceptive deficits, meaning that it's hard to know where the joint is in space and how you're using it. And we don't normally consciously think about all of these things. We certainly don't consciously think about what each muscle is doing. As Dr. Nojan mentioned, sometimes that temporalis tendon is involved, usually because we are overusing it to stabilize. That might be a point of pain. PT is really helpful for understanding mechanically what's happening and then helping unwind some of those mechanics and seeing what's behind that. So one thing that often happens with PT is people will improve their range of motion. They'll feel great after PT. And then we often see what's behind it. If the joint is hypermobile and you loosen up the muscles, the hypermobility will declare itself even more. There may be more clicking, more popping, which, of course, that's what we see if we over Botox a hypermobile joint. We're going to really expose that hypermobility through the loss of guarding. But really, the goal of PT is to bring insight into how the mechanics are being used and how they can be optimized, and then training that process. And of course, if you Botox the tight muscles, you'll loosen the tight muscles. This can cause a variety of side effects, right? It's quite common, and the reason I mentioned the med spas, it's quite common. They will just Botox the temporalis or the masseters, and they may not even get the deep masseter. They may just get the superficial masseter, because I mean these are the easiest to hit, and they're the ones people complain about the most. But the challenge is that they're not the only muscles affecting the mechanics of the joint. So now whatever has been done will alter the mechanics of the joint. Will it alter the mechanics in a helpful way or not? I mean, quite often, as you're hearing, it doesn't, because it's not done by intention. It's not done with a deeper understanding of what the primary issue is that's causing the muscle guarding. It's kind of just throwing Botox at a tight, sensitive muscle and hoping for the best, right? So without really understanding why those muscles are tight, what purpose each muscle is serving, you don't know the outcome. And even as Dr. Nojan mentioned, I've seen plenty of cases like this too, where people will get masseter Botox and they'll come in with an anteriorly displaced meniscus because the lateral pterygoid was really part of the problem, and that was not Botoxed. And that's why it was then overpowering all the other muscles. Sometimes the masseters are really working just to hold everything else together. You take away that ability, you don't necessarily know what you're going to set in motion. So that's why we really have to understand everything as we go into it. Steroid arthrocentesis of the joint, it's another approach. But again, you want to understand what the primary issue is. What is it that you're actually looking to treat rather than just throwing a treatment at it? You want to really understand what you're trying to accomplish. So when we take a step back and understand everything that can affect the TMJ, and of course, someone may know they're hypermobile. They may not know that they're also having an autoimmune process. They may not be aware of migraine. They may not be aware of the malocclusion or the bruxism or the PTSD, or maybe they are, but they don't realize that it's actually affecting the jaw. The sympathetic nervous system hyperactivity, which occurs with the dysautonomia, which also occurs with hypermobility frequently, especially if there's craniocervical instability. And of course, skip down to eye, craniocervical instability, C1-2 and C3-4 will both affect the jaw mechanics and can refer pain into the jaw as well. And of course, posture, as Dr. Carminati mentioned, primary orofacial dystonias and secondary orofacial dystonia. Dystonias are when there's a neurologic process driving increased involuntary tone through the muscle. And this is when Botox is appropriate, but we really have to judiciously assess for this. And even if there is orofacial dystonia, we want to make sure there's not some underlying hypermobility that will unmask and make things worse. And then, of course, primary myofascial pain, which is everyone's favorite because it's easiest to treat. You'll never need me if this is it, right? Like you can get some PT, some dry needling, you'll be fine. All right. So treatment based on the cause. If there's underlying hypermobility, we have to treat the hypermobility. And this is where I do come in. This is where we will use something like prolotherapy, PRP, to the joint and the stabilizing ligaments directly to improve the stability of the joint, the intrinsic stability of the joint. So we're actually treating the hypermobility to make the joint less mobile. Once we do that, then we can unwind all the muscle tension that is built up. We can release all the trigger points that have built up, and they shouldn't come back. Now, do I have patients with hypermobility coming to me with jaw tension saying, please just Botox my jaw, I just want the muscles Botox? Yes. Do I counsel them that, yes, we will often unmask and have more clicking, popping, possible more dysfunction? Yes, they often say, I don't care, I just want the Botox. And I say, okay, but when it comes back, when it starts clicking and popping, when things are getting worse, this is what we need to do, because really this is the only offering. Ideally, if we correct the stability of the joint, you won't need the Botox. You won't need to come in every 3 months to get Botox over and over and over, right? Because we'll be treating the root cause, which is the hypermobility. Now, might the joint stretch out again over time and we need to do more regenerative medicine? Maybe, but not always. I have patients that have, we've done several years ago and they're still doing great. So if there's hypermobility, we treat the hypermobility. Now, number two, autoimmune. I'm shocked by the amount of autoimmune disease we find in the TMJ. It's much more frequent than I was ever taught that it was, and we're only finding it because we're looking. And I'm looking with ultrasound, and these are patients who may have had an MRI of their TMJ, and it doesn't show up there. And again, as Dr. Nojan mentioned, MRI slices are 3 millimeters wide, and usually we send for an MRI of the the TMJ. We may only get one slice that goes right through the middle of the joint, and that's it. We've got one picture to look at. And if that one picture doesn't capture the erosions and there's not active inflammation, it's not going to capture the autoimmune process. And often these autoimmune processes come and go. Like patients aren't always flaring. So if you don't catch it during a flare, there may not be an effusion, there may not be swelling on the joint. We may not be able to call it based on the MRI, but on ultrasound, which I can do in the office, we can see these little erosions. It's like pumice rock, right? If it shows up, it's there. Like, this doesn't come from degeneration. This doesn't come from overuse. This doesn't come from repetitive clicking and popping. It only comes from autoimmune disease. That's the only way you get these erosions. And then sometimes you'll even see a synovitis, which again, generally you only get it from autoimmune processes. So if there's an underlying autoimmune, we have to treat that. Otherwise, there will be progressive degeneration of the joint. And I would very much like to look at that study that Dr. Nojan mentioned, because I have a very high suspicion that a lot of early undiagnosed autoimmune TMJ pain comes in as an orofacial dystonia or jaw clenching, and they get Botox for that reason. And then it's only with significant time that there's enough joint degeneration that it actually declares itself as a primary autoimmune. So I'm really more on the suspicious side that TMJ autoimmune is underdiagnosed. And so I'm a little hypervigilant about making sure we don't miss that, because I don't want to just, treat it and miss that, because then it will get worse with time. Now, as they both mentioned, migraine frequently activates the temporalis and the masseters, because they are both trigeminally driven muscles. So it's super common for jaw tension to get worse with a migraine, or to be felt with a migraine. And then, of course, there can be chicken or egg too. A lot of people will say, well, I feel my jaw tension causing the migraine. It doesn't necessarily mean that the jaw tension is causing the migraine. It may just be the first part of the migraine prodrome. And then as the migraine evolves, then it goes to the head. So it feels like it comes from the jaw. Same thing happens with the neck. And of course, if there's dental issues, then dentist. If there's bruxism, dentist, mouth guard, medications for the bruxism, like amitriptyline, baclofen. If there's anxiety, biofeedback is great for this. This is where Dr. Carminati can also be very helpful. Craniosacral therapy, biofeedback can be very helpful for, TMJ dysfunction related to anxiety. That also feeds in to the sympathetic nervous system. And of course, we can use vagus nerve activation to counterbalance the sympathetic, or we can do, down-regulating exercises, biofeedback for the sympathetic nervous system. And of course, if there's some underlying condition that's causing sympathetic hyperactivity, we want to treat that. If it's migraine, if it's endometriosis, if there's craniocervical instability driving that, and of course, if there's PTSD, we want to treat all of that. Now, all of these above things will cause biomechanical changes and postural changes that must be unwound with physical therapy. If we identify an autoimmune and we treat it, if we identify hypermobility and we treat it, there's still a pattern of overuse, disuse, compensatory behaviors that have evolved over time. And if we don't unwind those and restore normal mechanics, the jaw function will not be optimized for the rest of the rest of the patient's lifetime. So we really want to make sure that the joint is working evenly, smoothly, consistently, and not limited in its use in the same way that it had been when there was another process driving pain. Of course, if there's spinal issues, we diagnose that, identify the issue, treat the issue. If there is a primary orofacial dystonia, we Botox to control the muscle hyperactivity, and then PT for training. It's the same as we do with the other dystonias. You Botox the muscle to modulate the hyperactivity, and then you integrate physical therapy for educating the muscles on how they're supposed to be working and retraining those synergistic patterns that, have become subconscious. We have to bring them back to the consciousness for a bit to retrain them, and then they can become second nature again as long as the dystonia is controlled. And then, of course, if it's primary myofascial, those are fine. Just some trigger points and it's good. All right. So let me go into this specifically because this is what we're here for. So for treating hypermobile ligaments, aside from a surgical intervention to, plicate or tighten them surgically, really we have injections. And so we use dextrose prolotherapy. I will use 20% dextrose in the joint to stimulate a proliferative response in the capsule and the supporting ligaments to reduce the hypermobility of the joint. And when there's both meniscal degeneration and hypermobility, I will generally treat the hypermobility first so the joint is stable, and then I will use PRP to treat the meniscal degeneration. PRP is much better for healing structures, whereas the prolotherapy is better for tightening. If we just start with the PRP, we may heal the meniscus, but without treating the hypermobility, which is responsible for the meniscal degeneration, it's not going to last forever. I see this all the time with other joints, with shoulders, hips, knees. People have labral tears. The joint is extremely hypermobile. They get PRP and it maybe helps for 4 or 6 weeks, but then they're right back where they started because the primary issue is the hypermobility and that wasn't actually treated. And PRP can help with the hypermobility, but it's generally not enough. And of course, if dextrose doesn't work, if PRP doesn't work, we have more aggressive agents that we can use, but it's very rare that we have to pull those out. And then, of course, once that's done, PT to correct the biomechanics, to release a lot of the muscles. And this is rarely when I will use Botox. And the situation here is where that patient has been guarding for years and they've been overusing these muscles for years. And they are so used to overusing these muscles that the muscles are hypertrophied, the muscles are tight. And no matter how aggressively they're trying to PT it, they just can't break that cycle. So Botox in a judicious dose in this situation can be really helpful for rebalancing the muscles. And that's another point that I would like to make very clear is with all of the muscles, the 2 lateral pterygoids, the 2 medial pterygoids, the 2 masseters, and the temporalis, and even the temporalis has 2 functions, right? There's a jaw closing and a jaw translating. So there's really 2 functional parts of the muscle, even though it's one muscle. There is a role for Botox in rebalancing the muscles. So PT always try to retrain the muscles if you can. And if it gets to a point where the patient is not able to adequately rebalance the muscles, Botox can be tremendously helpful for getting a head start on that. And then the PT is much easier, much more effective. And then, of course, I put some pictures in here of autoimmune joints. So this first one shows an effusion. And this is why I'm looking at on the ultrasound. The one on the right actually shows erosions. And some of this flattening is also not normal, but you start to see a little popcorn look in here, and that's not normal. Same thing down here. There's a nice erosion, and then there's a degenerative bump here, which also often happens. So like with the hypermobility, with age, we will see degenerative changes, but it really needs to be like substantial age. If you're in your 20s or 30s and you're coming in with degenerative changes, that's not common at all. There was probably some jaw trauma. And Dr. Nojan, we can talk more about this and what you see, because we together we see a lot more than either one of us alone. And if you're in your 20s and there are erosions on the joint, that is highly suspicious for an autoimmune process. So when this is happening, if I see active inflammation, I will advocate for steroid in the joint to turn off the inflammation because the inflammation is destructive to the joint, or systemic NSAIDs. And then, of course, getting the patient to a rheumatologist ASAP for diagnosis and communicating your findings. Once the autoimmune process is controlled, hyaluronic acid is a jelly lubricant for the joint. So this rough surface has a little padding, and regenerative medicine like PRP can help restore some of the joint surface once the autoimmune process is controlled, not before then. All right. I'm going to go through a lot of this quickly, and then we can go through the rest with our questions and answers at the end. When there's craniocervical instability or hypermobility at the head-neck junction, that will affect the jaw. When there is a C3-4 disc herniation, that will refer to the jaw. Orofacial dystonia, I talked about this before. Again, generally not responsive to PT or oral muscle relaxers. Botox is the best option. And of course, we do it with ultrasound guidance. We talked through the Botox a little bit. It's every 12 weeks. It's best combined with physical therapy. You want to make sure whoever's doing it understands muscle balance and your specific overuse, underuse balance of the muscles so they can judge the dosing for each muscle appropriately. It's not just, I always put 25 in the masseters no matter what. And ultrasound is needed for accurate placement in the pterygoids, no question whatsoever. It's generally med spas don't do this. Generally dermatologists don't do this. There's very few people who use ultrasound for targeted injection of toxin into the jaw closing muscles. It's more than just getting the toxin in the muscle. It also allows us to assess the muscle. The hypertrophy, the size of the muscle, tells us a lot about what the muscle's doing. I can also watch that muscle activity with the jaw opening, closing. I can look at the neurovascular bundle of V2, V3, and I can see if there's compression. Sometimes the medial and lateral pterygoids are so hypertrophied, they'll actually compress the nerves there, and that can cause some neuropathic pain. Anyway, side effects of Botox. There's generally an adjustment. So we're rebalancing the muscles. There is always an adjustment period where the tightest muscles are no longer tightest, and you kind of have to relearn how to use the joint. That's where PT is very helpful. There can be some difficulty chewing initially, biting an apple, chewing a steak, things like that. There can be increased popping, locking, dislocation. I always advise patients when there's underlying hypermobility that this can happen. If it does, come back in right away. If there's any imbalance, we can fix it. There are plenty of patients, like I said before, where they got Botox at a med spa and they didn't get the lateral pterygoid. The patient comes in with a locked jaw, and it's because the lateral pterygoid has pulled the meniscus anteriorly. My solution, of course, is to then Botox the lateral pterygoid, which is a tough sell to the patient because they just got Botox and it made them worse. So I have the wonderful and uphill battle of explaining that it was the imbalance created by the Botox that we can only correct by getting that muscle to balance everything out so it's all on the same page. And yes, it will further unmask the hypermobility, but it's the only way to restore balance to the joint in the meantime. Then we will treat the hypermobility with regenerative medicine and get the underlying cause fixed. And then, of course, side effect rarely, crooked smile, which we try not to do, but it sometimes happens. All right, that's it for me.